Welcome, everyone, to the Canadian Nurses Association webinar series, Progress in Practice. CNA has partnered with Community Health Nurses of Canada, Community Health Nurses Leadership Institute, in a series of webinars to support the leadership development of community and public health nurses. This webinar, titled Public Health Leadership to Advance Health Equity, a Scoping Review. This session is being recorded for nurses who are unable to participate today. The information and views in this webinar presented by non-CNA staff are those of the presenters and do not necessarily reflect the official opinion of CNA. My name is Ruth Schofield, and I'm an assistant professor at McMaster University and the CHNC, or Community Health Nurses of Canada, Community Health Nurses Leadership Institute Chair, and I will be moderating this webinar. During and at the end of the presentation, we'll answer your questions, which you can type in the Q&A box, if you'll notice, to the right side of the presentation that you will see, and we will address as many questions as time allows. So this, as I mentioned, this webinar is the last in the three-part leadership series in partnership with Community Health Nurses of Canada, Community Health Nurses Leadership Institute. You can visit CNA's YouTube channel for the recordings that currently exist already for Part 1 and 2, which were the previous two webinars. And the third will likewise be available at the end, within usually a few days. So now I would like to introduce Clara Becker. Claire is a registered nurse and a certified community health nurse. She's currently an acting executive director with the Department of Manitoba Health, Seniors and Active Living. Claire is a past president of the Community Health Nurses of Canada, a founding board member of the Association of Registered Nurses of Manitoba, and currently is the president-elect of the Canadian Nurses Association. She recently completed a PhD in nursing from the University of Saskatchewan, and with a focus on public health, leadership, and health equity. And now over to Claire to start her presentation.
Thank you, Ruth. That's kind of a wild hair picture there, isn't it? Thank you so much. And before I get going, I just really want to say it's indeed an honor to be here this morning and to be participating. And I see lots of familiar names on the participant list. So hello to all my friends and all those that I've not yet met. I just really want to say a special thank you to all of you online and for the hard work and dedication that each and every one of you brings to nursing, brings to community health, and brings to equity work, and to your colleagues throughout Canada. And I just really want to acknowledge that the work is difficult and asks the best of us each and every day. So this particular presentation does actually highlight the research that I did for my PhD, for my dissertation, and I'm really feeling quite privileged that I'm able to share this with you. So this is our webinar outline. I'll talk to the learning objectives in just a minute, but I'm going to provide a little bit of an introduction to me and to sort of the space and place that I come from. Set some context for leadership and what I understand and what I found from the literature in terms of leadership. Share the results. I'll do that quite quickly in terms of the scoping review of the literature. It's always amazing to me that it took me 7 years to do that, and I can share it in 10 minutes. And then I'd like to share with you leadership description, or a description of leadership that I did at the end of my PhD or my dissertation. And then, of course, talk about some action. So that's our outline, and there'll be some polling questions along the way to get some input from you. The learning objectives for this session are to explore public health leadership to advance health equity, as was found in the research literature. Describe what I would consider unique attributes of public health leadership and the required support for that leadership. And then I'd really like to have some interactive, and it will be typing in interaction. So I hope you're at a keyboard and you're able to provide some input. Ways that we can apply the findings of this research, both in practice, policy, administration, education, and research in terms of nursing. Okay, so a bit of an introduction, and those of you who know me have seen this slide. This is where I lived. This is Souris, Manitoba, just about 4 miles north and east of Souris, Manitoba, where I lived. This is in the late 70s, actually. And this was my first practice in public health nursing. And I must say it was a very, very formative time for me, where I learned about community, I learned about population health, I learned about public health, I learned about relationships, I learned about working as part of an interdisciplinary team, about being guided by and in respectful relationships with community, both individuals, families, communities, as well as the population overall. And so I began my career in a one-nurse office in southwestern Manitoba, and as a public servant then, and now we worked within the district nurse model. So definitely a generalist from preconception to death, actually, to palliative care at home. And I had the privilege to work with strong leadership at that time and as part of a strong interprofessional public health team. And that's where I cut my teeth, so to speak. And 41 years later, I've worked at local levels, at regional levels, provincial levels, and at a national level. And right now I'm back working with Manitoba Health, with the Department of Health at a provincial level. So it's from that space and place that I continue to draw my inspiration and my energy from stories of practice and the stories that I hear along the way. Nursing is in my family, both past and present, and so you can see the one there that says 1922, Prince Albert, Saskatchewan. The shorter woman on the right is my maternal grandmother. And I mention her because she graduated in 1922 from Prince Albert, Saskatchewan in a faith-based, you can see, organization, School of Nursing. And she died at 27 of work-acquired tuberculosis. And I mention it because tuberculosis is still here with us. We still haven't wrestled that one to the ground. And she died before Medicare. So she died before there was a funded universal health care system. So I had a very direct impact on my mother and on my family. And the other woman, the other picture, 1943, is my mother-in-law, and her name was Clara Becker, and I was privileged to be in her family, and she taught me a very strong sense of community, of rural life, farm wife life, and was also a nurse and supported me throughout my career. And those are my daughters with me in 2016 in St. John, when I was elected president-elect of the Canadian Nurses Association. Kate on the right and Stephanie on the left, and they are nurses and registered nurses here in the province of Manitoba. So it's definitely in my family. So a little bit about my leadership journey, and I put here my certification. As Ruth mentioned, I am a certified community health nurse. I'm proud to wear that pin. I was part of the inaugural group that wrote the exam, developed the exam, so I actually didn't have to write the exam, which was a good thing at the time, but I have remained a certified community health nurse since 2006. I was heavily involved with the Community Health Nurses of Canada, and I'm proud, still a proud member, and I'll see you all in Regina at the conference there. But I also was a founding member of the Association of Registered Nurses here in Manitoba, as the Regulated Health Professions Act shifted our landscape here in Manitoba. And I'm proud to say that association continues to grow and continues to make a contribution. And of course, with the Canadian Nurses Association, this is my second time on the board, one time as representing the nursing specialties, and now as the president-elect, and in June as the president. So much of my leadership development and my leadership journey has been a combination of all of those things as I've moved along, and I believe that we're all leaders, and we all must lead from wherever we land, and really it's through our collective voice and our collective action that we work with communities, with the people within communities, to create the conditions where people have an opportunity to be healthy, and in doing so, we support the sustainability of our publicly funded healthcare system. Okay, so let's talk then about leadership and the context for leadership. And I find this quote to be a really interesting quote because I think it's actually quite accurate, and it's by Kouzes and Posner about 8 years ago, where they said that actually the content of leadership has not changed much at all over the decades. However, the context has changed dramatically. So as I speak back to my beginnings in the late 70s, the context of what we're looking at today, I in no means mean to say that what we were looking at as public health nurses in that day is the same as it is today. The context has changed dramatically and continues to change dramatically around us. So many of us, and here in Manitoba, it's absolutely true, we're in the middle of health system transformation and transition. And this comes from a video, actually, you can find online in March of 2018 by Sister Elizabeth Davis in Newfoundland and Labrador. And she talked about 4 major transformations, one yet to come here, in the health system over the history of the health system. The first being Medicare, and as I mentioned, my grandmother, and she was not eligible for medically necessary services in terms of her condition and what eventually took her life, provided in hospital or provided by providers, usually physicians. And you can see some of the major shifts there. So that was really the first major health system transformation in our country, as Sister Elizabeth Davis describes it. Second one was the advent of the Lalonde Report in 1974, built upon then by the World Health Organization's Ottawa Charter in 1986, which really introduced that notion that much of what determines our health lies outside the health system. So things like the social determinants of health, the population health approach, or the notions of population health, and also health promotion. And for those of us that were working in those times, it was a very inspirational time as we really started to understand things in a different way. And then, of course, other than Ontario, through every province and territory, there was the regionalization, which moved care closer to home, was able to engage with the community, promoted an interdisciplinary and an integrated service delivery model. And that occurred across the country and has continued to sort of transition and move, if you will, since the mid to late 90s. But she asks a really important question. So what's the next transformation? That was 20 years ago, right? Mid-90s. So what do we need to happen right now? And many of us are in the middle of those kinds of transformation. And I'm going to suggest that we need strong leadership, and we need strong leadership from a public health, prevention, population health perspective. This is just highlighting some of the forces that are going on around the world globally that really do impact on those things that influence health. So globalization is occurring, has been going on for a number of decades, not going to change. Urbanization, I know in our province, that urbanization of our population has impacts on what helps people to stay healthy, what determines their health, but also how we deliver services. Urbanization, I said that the aging population cannot ignore that as the demographic shift, and we see that larger aging population. And then, of course, health disparities. And I just wanted, or health inequities, and one of the things that Sister Elizabeth Davis also talked about is that while in that particular video, is that while we're doing well in some areas of the health system, we are actually not serving certain populations. It's right in that health disparities bullet there. We're not serving them well, and she named 5. She named those who are older citizens, seniors. We are not serving the mentally ill, our Indigenous population, newcomers, and refugees. And I'm going to blank on the 5th one. It'll come back to me. But so newcomers and refugees, the Indigenous population, mentally ill, seniors, And the poor, how could I forget that? And the poor, those that are challenged in terms of having sufficient income. So she really challenged people to look at those populations. Okay, it looks a bit like my screen has frozen here, Leah, so could you advance that slide for me?
Do you see the change?
Yeah, it's come now. It's changed now. So this is an interesting slide from the Canadian Medical Association, and it really does show that while only 25%, and we know this, those of you online, we know this, we see this every day, that only 25% of what determines health actually lies inside the formal healthcare system. Yet, and in our province we're no different than this, about 50% of the provincial budgets are spent on health care. So we're spending half of provincial budgets on 25% of what actually determines health. So again, even from an economic perspective, there's a call for a transformation. Okay, what about nurses? This is from a couple of slides that Mike Villeneuve uses, where that in a recent poll, 2015, they found that the vast majority of Canadians expect healthcare professionals, so nurses, doctors, health researchers, scientists, to actually exert leadership. So they're expecting us within the system to be actually exerting that leadership, that influence, that persuasion to improve not only the health system, but also health. And this, I think, is a really interesting quote from Stephen Lewis, where he's suggesting or stating very loudly that in nursing, that combination of nurses, reputation, and reach really should translate into power and influence over how healthcare is financed, organized, and delivered. Yet, we in nursing, collectively, the hundreds of thousands of us, we punch below our weight, and he believes that the country is worse for it. So a very, I think, compelling quote that pushes us to really consider our leadership role. Again, just looking at the system from what we have right now to the system that I think we need and where the leadership is required to get there. Right now, we're very focused in our healthcare system in the downstream. We really need to focus upstream, and anybody who's paddled or rowed going upstream and against the current, as I started out with, is not easy work and requires lots of rowers and lots of paddlers to move in that direction upstream. Right now we look at determinants of care. We really need to be looking at determinants of health, and I would challenge also the health equity or inequities within that. We have an acute treatment-focused system. We look to rescue and to cure, and we actually do that not too badly in our healthcare system. But in the future, I'm going to challenge, we need one that's looking at non-communicable disease, some of those other communicable disease, like the tuberculosis that's still there, aging, end of care, stigma, other things that are there. Right now, we tend to bring people or patients, as this slide says, to care. What we need to do is bring care, bring service, bring conditions to people. It's provider-led right now, really needs to be person and community-led in the future. It's physician-focused, and physician often the gatekeeper still, and team leader. It's interesting, when you've been around for many decades, we talked about this when I was a university student as an undergrad. But really looking at right provider, right place, right time, and right care, and nurses play a huge role in that piece. And then really looking historically as health human resources as being driven by the size of the population and the number of the providers. We're really needing to be looked at by needs of the population or issues within those populations and provider competencies. And again, we know that, and we've got the competencies in place and to work from. So how do we get there? I'm going to suggest that the way forward is really through strong, persistent, and intentional leadership. So we have a polling question for you right now, and we're going to have you answer that question.
So
as I kind of move on. So I'm just going to leave that, but I'm going to continue to talk while you answer the questions. So if you could kind of interact with us in a way here, that would be really, really helpful.
It's Ruth. You'll just notice for those, as you see the screen, to the right of Claire's slides, a Q&A section. Feel free to type in there, or actually in that poll box there's a section for answers, and you'll be able to see each other's responses. So everybody will see your responses.
So somebody's already answered there and saying consistent. So I'm going to keep going and talking, but just you've got a few minutes here to really kind of answer how you define or describe. I actually sometimes find the word describe opens a little more space for me to think within than actually defining, right? Define for me sometimes makes it feel like there's a right or wrong answer to it. So while you're doing that, I'm just going to move on. So for my dissertation, I spent a lot of time in the leadership literature, an enormous amount of time. And I'm going to tell you that there's a lot of it. There's a lot of people who hold, very strong opinions about leadership and what it is and how it works and what's effective or not effective. So there's a huge body of literature, very little research. So the empirical evidence is very thin. Most of what's written is theoretical, opinion pieces, books, and not to diminish that, but just to know that that's the body of work that's available. And much of it is in the form of popular literature, if you will. So it's actually accessible in libraries, public libraries, in bookstores and whatnot. But these are just four of some of the quotes that I found really interesting, that leadership is actually considered to be one of the most complex of human constructs. So while it may also explain why there's not a lot of research, it's difficult research to do. And Burns, who tends to be one of sort of the classic writers, in his book in 1978, and he wrote many sort of iterations of leadership books, if you will, after that. But he said that almost 40 years ago, he wrote that it's a universal craving, that we actually are craving compelling and creative leadership, that we look for it, that we're actually as human beings drawn towards it. He also said that while leadership is one of the most observed phenomena, that it's actually one of the least understood. So that was 1978, and I think there's been some advancement, but not a huge amount, actually. But I thought this was a really interesting quote as well, is that we know it when we see it, but few can actually define it clearly. So how are we doing in our polling?
Where'd it go? Sorry, it just disappeared. So we've had a number of responses in ideas about what leadership is that's kind of touched on it, and unfortunately I can't see it right now. So why don't you carry on?
You can see it now, Ruth. Yeah.
You do? Okay. I don't.
Yeah. So people are talking about working collaboratively, about guiding the way, helping others to find voice, inspiring, motivating, listening to those right at that interface, right at the frontline staff, using influence and power to create change, beautiful, creating vision, leading by example. Yeah, you're always being watched, right? People are always noticing. All of us are kind of looking and watching each other, so you're a leader all of the time. You're leading all of the time. It's influence, values. That's an interesting, we'll come to that. You're pretty smart, this group. Looking at the strengths and weaknesses of your team, right? Trying to shore up those weaknesses. Creating an inspiration, motivation. To move a thought or an idea forward. Yes, it can be very small, not massive change and transformational change. Sometimes it's just about embedding an idea and moving things forward. Yeah, keep going, keep describing, and I'll move on. So for Chapter 2 of a dissertation, you have to do a full and comprehensive and challengeable review of the literature. And so I did that. And actually, the NCCDH, along with myself, published, and the link is right there, on a bit of a summary of Chapter 2. So what's out there in the literature? And really what I found was that there was actually 5 common elements of leadership in that big thing of leadership. So vision, values, communication, relationships, and as you said in the poll, change, right? And empowerment was there. So in terms of vision, leaders, they create, they express a vision. That vision unifies us. It focuses energy. It points towards solutions. It points towards change. It's often through that vision that power and influence is created. And that importance of vision is really, really clear in the leadership literature. So as we develop as leaders, we really need to think about and articulate and give voice to our vision. And in public health, I think it's actually a commitment to actually knit and align perhaps even disparate views into a common vision and a common mission. Values. Burns actually called values power resources, and that those values were at the core or the sort of center of any kind of transforming leadership. And knowing what you value and what your values are, even though they might change over time, they actually strengthen leaders and their capacity to reach out to wider audiences. So really that self-reflection and knowing who you are and what you stand up for. And public health is grounded in core values, in core concepts of human rights, social justice, solidarity, fairness, doing what's right, the greater good, and those kinds of things. So with public health leadership, I don't think we can get away from values and need to be very clear about what our values are. And in the core competencies document in Canada in 2008, we said that it was a commitment to equity, social justice, and sustainable development, a recognition of the importance of the health of the community as well as the individual, and a respect for diversity and for self-determination. So 10 years later, those values actually would still hold us up, I think. Communication. And this is multiple levels and multiple types of communication, and I know I still can find myself struggling in this at times and looking to develop and continue to hone my communication skills. So things like negotiation, conflict resolution, helping to find that common ground and move mitigation, if you will, mediation, moving through with multiple viewpoints, I think are skills and communication skills that are really important. Finding the appropriate words, being able to teach, being able to effectively use media, which I'm going to say I shy away from. I may have to get used to that and a little bit more with the CNA presidency role. But being able to engage with others who have other communication avenues like journalists, writers, advocacy groups, civil society, help us to really articulate our critical ideas and be able to bring those solutions forward. Relationship, leadership is all about relationship, and one of the most important relationships is that with our followers. And being a follower requires, in my opinion, a very high level of skill and knowledge, being able to see that leader, see that leadership potential, and being able to put our shoulder behind what that leader is moving towards. So that relationship between leader and follower is a really important one, and one that's just emerging in the current leadership. So at the core of that relationship is actually efficacy and self-efficacy, the notion of being an individual within a collective, feelings of self-confidence, deep self-confidence, hope, expectation that goals can be attained, and that problems can be solved, whether it be through individual effort or collective leadership. But it's really interesting to me on that sort of really go forward perspective, those highly relational skills in public health actually, from a broad public health perspective, don't actually reflect that sort of technical and academic skill that traditionally public health has been founded upon. So I think as we move ahead, collectively, all of us within public health and in community health, we really need to think about what those relational skills are and really practice with each other and collectively to hone those relational skills. One that I've heard recently is being an ally, as a way of being in relation with another is as an ally. We've talked about champions, we talk about the coaches and leading and following. But the notion of ally or walking beside or shoulder to shoulder or becoming on side with another, I think is an interesting concept in public health in terms of relationship. And then finally, change and empowerment, and which goes with the vision part, because actually leadership is to come to a different place, right? To an outcome, to a change. And having a vision is that you envision something being different and moving towards that. So effective leadership, as you said, motivates, inspires, and as a result generates that energy to move towards change and to be able to cope, I think, with the barriers and the stumbles and the sort of resistance, if you will, that comes in terms of change. And Burns actually said that realization of an intended change is considered the ultimate test of leadership. So I think when we hold ourselves up and look to see whether we've been effective leaders or provided effective leadership, it is about, did we get towards that vision and towards that intended change. Okay, so a definition of leadership, and let's see how yours matched this. This is generally what one of the definitions of leadership that I found helpful. So that leaders induce followers to act for certain goals that represent the values and the motivations, in other words, the wants and needs, the aspirations and expectations of both the leaders and the followers. So that's like 40 years ago, John Burns said this. Okay, so if we move on then and think about more specifically and out of that broad perspective, and you're thinking about public health leadership, these are some of the definitions or comments about public health leadership, and then I'm going to tell you about my research. The public health leadership includes personal traits, roles, processes, functions, commitment to the community and the values on which it stands. It occurs at multiple systems level, individual, team, organization, community, as well as at societal level. Health leadership, again, this is back to the glossary of the Public Health Agency of Canada, the core competencies. And again, it has words that you use: influence, motivate, enable, looking towards effectiveness and success, change, if you will, in the communities or in the organization, inspiring people to craft and achieve a vision and goals. And some of the skills or techniques, if you will, leaders that this definition talks about as being a mentor, coaching, recognizing, acknowledging, and encourage empowerment, and they actually work to allow other leaders to emerge. So bringing it back to nursing, because this is about Community Health Nurses of Canada and the Canadian Nurses Association. This is a position statement by Canadian Nurses Association, and I've also got the Code of Ethics there. But it really talks about nursing leadership being at all roles, all domains. And one of the comments it talked about listening to frontline. They are leaders. So sometimes not sometimes, probably often, we need to follow those leaders at the front line. So we're all leaders. Our work and our leadership is grounded in social justice and the use of our critical thinking skills. It's action-oriented. Nurses are about action, about doing something that takes us to another place. Advocacy, including advocating for healthy public policy, for good, solid public policy. And as you can see right in the very first sentence there, it says nursing is a practice discipline and it is a political act. So really defining nursing leadership, CNA, in terms of the political piece of it. Okay, so I think we have another polling question here, which is actually up there, but really asking you to think about how you might then define public health nursing leadership or community health nursing leadership. What would that look like for you? And you can continue to answer that question. So this is a definition that, and I tell this story, Diane Buick from Middlesex London Health Unit at the time and myself had embedded in on page 135 of a chapter in Stamler and Hughes' textbook. We did not intend to define leadership here, but I was actually at a presentation and I saw this up on somebody's slide and I thought, I didn't know we defined leadership, but this is what we had said in the chapter and I've used it since then. So we said that community health nursing leadership is about influence that moves individuals, groups, communities, and systems towards achieving goals that will result in better health. So that's a pretty simple, I think, concise definition of public health leadership. So you add what you would like in the poll as we move along here. So it includes advocacy, and there's Florence Nightingale, and we're just a week past the National Nurses Week, which includes Florence Nightingale's birthday on May the 12th, which was Saturday. And this is one of her quotes that says, "Were there none who were discontented with what they have, and the world would never reach anything better." So go back in your mind to that green slide where I talked about the health system as of where we are now and where we need to go. And I think we are discontented right now and with what we have. It's not necessarily addressing those, as Sister Elizabeth Davis suggested, those 5 populations, and there could be other ways to think about it. But there are people who are not benefiting from the health system as we have it right now, and so we wouldn't reach anything better. So these, I'm just going to put 2 quotes up here that I find inspirational, and this is from Adeline Falk-Raffel's article that she wrote in 2005. And to me, this really speaks to our space, our unique space as public health nurses, as community health nurses in this work, that we actually work every day, you actually work every day at that intersection where societal attitudes, i.e. our values, what we are willing to tolerate as a society, so societal attitudes, government policies, again back to that policy work, the political work, and where people's lives meet, like we're right there. And that creates a moral imperative, not only to attend to the health needs of the public, but also, like Nightingale, to work to change the societal conditions, back to some of that Lalonde work, Ottawa Charter work, that sort of second transformation that I spoke about earlier, contributing to poor health. And then in the research study that I did with Adeline as part of my doctoral work, one of the participants talked about it being a trombone slide, that actually witnessing social injustice downstream in communities and neighborhoods creates a leadership, opportunity, and I'm going to suggest an imperative to advocate for and work toward health equity upstream. So that trombone slide is what that particular participant talked about. And what to me, the question that then comes out of that is, so somebody asked me one day, so Claire, what's the trombone? I don't play the trombone, and I don't even know anybody who plays the trombone. And she said to me, so what's the trombone oil? What makes that trombone actually slide from that downstream and that meeting of the needs of the individual or the neighborhood or the community, and then upstream to addressing the social determinants of health and the health inequities that exist and actually are getting larger. And I'm going to suggest it, again, it's leadership. That is the oil on that trombone slide. So I'm going to talk a little bit about my research. We're sort of 40 minutes in here. Like I said, I can do this really quickly now, and it does reflect seven years of work. There are a couple of slides in this next group where there's an opportunity for you to answer some questions, and we're going to suggest in those that you actually type them right into the Q&A piece. So I'll just move along here and you'll see when they come up. So just a really quick background. Not only myself but others have called for leadership, in particular public health leadership, to advance health equity. The 2 environmental scans of the National Collaborating Center for Determinants of Health both identify leadership, strong leadership, effective leadership as being required, absolutely required. David Butler-Jones in 2008, in that first report on the health status of Canadians, he said health equity is a priority for action and leadership is required. And then we have competencies, the leadership competencies that were developed and are on the CHNC website in 2015, as well as the core competencies. Well describe what the competencies are in terms of leadership. But I really wanted to know what type of leadership is required in public health. How is it described? How is it developed? How is it supported? Is it unique? Is there anything in the research literature that would point a direction there? So I found some here. This is very skinny, a little bit of discussion in the literature, the recent literature about public health leadership for health equity, but there was hardly anything in any of the literature that actually looked at that. So it talked a little bit about political will, interpersonal skill, science, having knowledge, skill, attitudes, the ability to link your organizational activities with community and things like that, but it wasn't satisfying. It didn't actually answer my questions that I had. So I did what was called a scoping review, and this was my research question. What aspects of public health leadership to advance health equity have been considered by research? Because we thought at the NCCDH, and I was working there then, that there would be some research literature available that we would be able to summarize or synthesize and answer this question. And so we did what would be called a systematic review of the literature, and actually it was an empty review, and then went to a scoping review, and not really looking always for leadership literature, but looking for literature and research where leadership was part of it. So we used rigorous, or I used, and I'm not supposed to talk in the we, I used as a student rigorous processes of systematic reviews. I looked at, and part of the research team with me looked at about 8,000 citations and had really strict and evolving or iterative inclusion criteria. In the end, there were 27 included studies, and they were mostly descriptive or exploratory studies, which does point to the maturity, if you will, of the body of work that's available. Equity, or the other words, inequality, because that's what's used often nationally in Canada and also in the UK, and disparity, which is often used in the US. So I let both of those kind of words had to be considered in the study. And there had to be leadership as some aspect of it. It needed to be a research study, and it needed to have an intervention of some sort, and it needed to describe outcomes. So a change had to have occurred as a result of the intervention and then the research of it. 5 of them were program evaluations that were published. I used the 6 phases of Artsky and O'Malley's method, including an online validation and augmentation phase. So what I'm going to present isn't just from the 27 studies. It also was validated and augmented by the online survey. What's really interesting is in those 27 studies, there was actually 26 theories and frameworks that were mentioned in 21 of the 27 studies, and they were all different. There was only one that repeated, and it was a different slant on the same name of a theory. So what that shows us is there's no real consistent theoretical framework for public health leadership out there, actually, but there's a lot of interest in theories and frameworks. Sometimes the studies resulted in a framework, sometimes they used a framework, sometimes they just mentioned a framework along the way. Sometimes they used a framework for their data analysis. Anyway, it's an interesting thought. So So these were the findings in a nutshell, and they're also summarized in another document that the NCCDH and myself, Diane Oikel, helped me and wrote it with me, that summarizes the findings, and it's available in the last couple of months on their website. So leader attributes matter. Leadership in public health to advance health equity is relational. Leadership requires knowledge, and it was very particular and interesting, the kind of knowledge that was there. And leadership requires support. So I'm going to just go quickly through those, but I'll start with the attributes, and then I have a question for you. This always, when I present this, these always engender discussion. It's really interesting. So some of them are not necessarily surprising, but I'm going to ask you a question in a second. And you can see them there. And maybe I'll just move to the questions, and you can start to type in your answers, because people actually have interesting responses to these. So there's our questions. What surprises you? Do these resonate with you? And which ones do? And in your mind, how are these developed, or how are these actually acquired? So I'll just kind of walk through them while you start to answer our questions. So in those 27 studies, what came forward is that leaders, the attribute of the actual leader was that they were visionary. They were often described as passionate and charismatic. They were able to inspire others, back to that notion of leader-follower. And they were really motivated to be involved. They were those kinds of folks that rolled up their sleeves and got down to business, if you will, not unwilling to do any myriad of different kinds of roles within these studies and these projects that were going on. They were connected to the community. Some of them were actually members of the community, came from the community. Others did very intentional actions to get very connected to the community. They were effective communicators, both at an individual, family, as well as a large group perspective, and they were able to use media. They were trusted, they were respected, and they were seen as credible. And sometimes their educational background, i.e. they were physicians, nurses, dietitians, that they were seen as, they were given that level of trust and credibility by their designation, if you will. They were more often than not oriented to values, for sure, and their leadership appeared to be value-based. But the values that were there were social justice and solidarity. But at the same time as being visionary, passionate, and charismatic, they were humble, they practiced humility, they were caring. In 2 of the studies, the word love was used. They loved the people. They were loved by the people, and they loved them. And they were patient. They knew that leadership and this kind of change took time. So, what surprises you about those attributes? And do they resonate with you? And which ones? And how do you develop those? Often people will say to me, well, did you have to be born with them? And there is a body of work that talks about the old sort of thinking that leaders were born. More modern and contemporary leadership theory and literature says we can learn the skills, we can hone the skills, we can practice them, and as the context changes, those leadership skills actually need to adapt and move with that. Interesting, Pam says that trust resonates. And it's interesting, someone said to me the other day, an elder actually said that respect comes first, trust follows. And so really back to that humility and caring and respectful stance is then would move to that trusting piece. Okay, well you can continue to contemplate that, and surprised that knowledgeable is not there. Yeah, that's I've heard that before too. Mm-hmm. Others saying that none of these are surprising. Yeah, courage, integrity, that's another one people mention. Yeah. So remember, these came from the 27 studies in the research studies that actually in the screen that are published, right? That are out there. Okay. So moving on, leadership is relational. So these, I know you won't find surprising, but the leaders worked in partnership, they worked in collaboration. They were able to build coalitions, and they were able to build those bridges, right? That kind of bridging between community, leaders, organizations, other sectors, that sectoral work. The leaders in those studies, they were skilled. They had high skills at developing relationships, and they often brought relationships with them. And those of us who've been around for a long time know that, sometimes it's those relationships you built maybe a decade ago that really serve you well in a leadership role as you move ahead. So they knew who to talk to, they knew who to listen to, and they were able to reach out, and they had the courage to reach out. They acted, those leaders that were described in these studies, as community champions. They encouraged and inspired others to lead. They engaged the community. And they were able to build what is understood as social capital, sort of that interconnectedness in others. So they didn't just interact themselves, they actually helped others to find each other. One was a leadership hub, another was a coalition, another was an advisory group. Those are the sort of the entities or processes they used. They acted, but they also enabled others to act. So they provided support, and they were effectively back to that notion of negotiation or conflict resolution or mediation skills. They were able to negotiate that shared interest and that collective vision. And they were able to engage right from some of them at that political level all the way to right with the people on the ground, in the homes and on the streets and in the communities. And so they were able to build supportive and empowering relationships and enable others to act. This was a really interesting piece, and actually I should have expected it and didn't, but that there were different kinds of knowledge that was required. So contextual being about the community, and this often came through intentional or deliberate processes like community health assessments. But it's through that contextual knowledge that they were able to raise awareness of issues, to engage with the community, and they were able to use multiple forms of evidence, so community voice, community information. Situational was really being able to apply the concepts of cultural competence, cultural safety, health equity, social and structural determinants of health, being able to see those people within that situational perspective, if you will, and having that knowledge of kind of those other global or broader forces that are at play here. So they had knowledge of the social and historical context, some of the societal processes and patterns, what had worked in the past in communities, the social, the environment, the economic conditions, and the influence of settings and where people found themselves. And then clinical, and I added practice there, but this came really from their technical or formal education, and I mentioned medicine, nursing, nutrition, sometimes community development, community mobilization kinds of formal training, and often through advanced education. But they also required support, and we have a question around this too. So these were 8 different, and I literally plucked from the 27 articles these different ideas about support. So I'm just going to ask the question here and get you to kind of respond and kind of work with us a bit around these. So these were looking at supportive processes, structures, models, the use of having access to relevant and usable evidence, impossible to lead in some cases without that kind of data and information about the community. I mentioned community health assessments. That in some of the organizations they had equity-informed policy and program development that was institutionalized, and it made their leadership, it enabled the leadership. There was adequate practice development, professional development, and there was adequate staffing. So that workforce and practice development enables leadership. This is an interesting one, is around having active and facilitated discourse or discussion about values, ethics, leadership, political activity. A couple of these studies actually came right out of quality improvement, accreditation, evaluation kinds of things. So they actually came right out of that and then moved into this project, which they actually researched and published about. Again, back to this relevant conceptual and theoretical frameworks. They were mentioned multiple times in these studies, but really saw them as a tool to guide practice. And then finally, I think 6 of the studies used community-based participatory action research and actually using those processes as a leadership tool or catalyst was in those studies. Okay, so just about done the dissertation. And I think Ruth, and I think I might just keep going unless there's some question in here that you saw that you might think we should stop to answer. And then we can open it up for discussion. I was just going to share a description of leadership that came out of the dissertation, and then we could maybe have a discussion. What do you think, Ruth?
Yeah. Many of the comments, as you mentioned earlier, do tend to resonate with what you found in the literature. Not too many surprises that came through. And I think there's a little mention about development in terms of that being ongoing, that we continuously need to work on development, I think Marlene mentions. And then there's the context of that Kate brought out in terms of how this fits in language of labor unions, and just not sure how that works. And so there's some unique applications of where leadership applies it kind of came out. And that was more, I think, in relation to some of the attributes. And I think maybe we can hear a little bit more about some of the strategies, whether what you found in the literature really, you do resonate with some of these strategies identified on this slide that we now see. Does that make sense that they, in fact, are advancing leadership and giving us that opportunity to develop that capacity around leadership and being leaders?
Okay. So I've got a few more slides here, and then I think we're going to move to action. So I think if people start to have some questions or some broader comments, I would welcome them. We have a few minutes left before the top of the hour, and then we have actually, I think, up to another half hour afterwards if there is a discussion or conversation we want to have. So I'm just going to move on then. So when I got to here, this was sort of 2/3 of the way, or probably enough to get the PhD. But I was now really curious about developing my own description of leadership, or a description of leadership that then could maybe be tested or used or further developed. So I dove back into those 27 studies. So I'll go here right before. This is actually the NCCDH's absolutely current, fresh environmental scan. And they talk about building a culture of equity, and it's really interesting how aligned these 5 different mechanisms, or they call it areas for action, line up with what I found in the study. So that was just really interesting to me. So you can look for that document, and you can have these slides, and those links are right there. And it's really just in the last, I think, few weeks, this 3rd environmental scan has come out. Okay, but I wanted to know a little bit more, and I wanted to describe leadership a little bit more in detail. So I went on and I did what's called a meta-summary, which would be like a meta-analysis with quantitative data. I did a meta-summary with qualitative data, sort of an emerging synthesis method, and Sally Thorne actually has done a lot of work in this, so it's kind of a nursing methodology, if you will. So I did an in-depth data extraction in those 27 studies, and I pulled out 510 verbatim data elements. I developed a bit of an analytical framework, and then I did a just a really classic thematic analysis, just, what goes together. These stickies, and anybody who knows me knows I love stickies. This is in my living room, but it's also in Tanzania, in Africa, where my supervisor, Dr. Pamela Petruka from the University of Saskatchewan was, because I needed her brain and I needed to be beside her. So I was down there and I came up with these descriptions. And how they coded or themed was into 5 broad themes. and I then did a word cloud, and you'll see them here. Put them into word cloud maker program called Tagexco, and you can find it online. It works well. And I pulled out the major words because we already knew those, and then I used the words that came out most often in those stickies that I coded into these 5 themes, and then I made a paragraph about them. So I'm just going to read the 5 paragraphs, and then we'll open it up for conversation. So these words came from these stickies. So leaders are staff, so right back to that front line, members of the community and champions. Their skills and confidence, I would suggest courage as well, are enacted through their roles and their practice, i.e. their work. They lead by providing support, by establishing partnerships, by being engaged and involved, and supporting the development and implementation of services, programs, and policies. Their work occurs locally and is fueled by their commitment, which I would suggest comes from their values. At an organizational level, the organization supports leadership also through its work, including projects, programs, policies. The structures and processes of a public health organization support the community as well as its employees. So be seeing ourselves as situated and part of that community. The organization provides support and advocacy on important health issues. The organization provides training and education within the organization and with community partners. The organization works to be successful and address the social determinants of health, including racism. And it was one that came out in this word cloud. Leaders and partners, this is at a system level, build coalitions, engage in political activity, are involved, and provide support. And you'll notice the word support comes out over and over again in these descriptions, which I think is, again, an interesting sort of thing to think about. Capacity building and policy are tools and resources used at this level. Interventions and leadership action occur at a societal level and at a local level, reinforcing that context matters. At these levels, evidence, change, and disparities inform action of the leaders. Remembering that about half of these studies were from the U.S., so you could insert there health equity, not disparities, health inequities. There were 2 notions that I think are really interesting and unique to public health leadership for health equity, and one is this bridging idea or an enabling idea. So participating, collaborating, engaging, and partnering were processes that facilitated the bridging and enabling dimension of public health leadership. Through structures and processes, action is taken and support, again that word, is provided. Participating in political advocacy as well as building capacity strengthen the leader's ability to enable others. And enable came up in the word over and over again. And if you kind of couple that with the support, it's kind of an interesting set of ideas, with leaders working most consistently at a local level to address inequities or disparities. And finally, values. Community members, leaders, and politicians work from personal values, beliefs, ethos, and ideology. Justice and the importance of reflection on the social determinants of health disparities and marginalization figure strongly in public health leadership. These values play out in society and in community, informing how health and health issues are addressed, as well as programs are developed. So just to summarize, and then we can open it for some conversation from my dissertation, public health leadership for health equity includes the attributes of the leader. It includes knowledge and support. It is relational. It occurs at multiple levels. It incorporates this notion of bridging or enabling, and it is rooted in values, and I'm going to suggest in the values of social justice first. So that was what my conclusion from my dissertation and from my research. So,
yeah, we have some very bold comments now coming through, which is very interesting. And Lisa, I like what you said, and I think it does challenge us that we in nursing are stronger at leading with individuals and supporting and influencing change, but at a broader system level, much more of a challenge as nurses. Good point. And Marlene, yeah, nothing surprising. Yeah, again, yeah, good.
Okay, so maybe we'll just finish up then. One of the things we wondered about is action. So the next few slides are some of my thoughts around action.
We do have a question before you move on. We do have Pam
Okay.
that's asked a question. Did you find any literature that supports a flexible leadership style? Although consistency contributes to trusting a leader, leaders' responses should not be necessarily be predictable. Different contexts or situations may benefit from situational-based styles.
Bingo. Bingo. And actually, I often use the word chameleon. That actually, and not to hide, but that almost, and again with that list of attributes, right, from charismatic and passionate to humble and caring, right, that really having that stance or way of being in the world, having that repertoire, if you will, allowed the leader to either match or to, facilitate within the place that they are. So yeah, situational leadership. And I actually think in public health, because we have that sort of tactical, and in nursing, we have some tactical and, if you will, command and control leadership skills. Like, we know how to get a job done if there was an urgent or emergent situation. We've all had those kinds of experiences. But, and then moving through that notion of transformational leadership, but almost into that transcendent, which is more about collective action and really being following the lead of and following along with what the community and what the leadership and that notion of, again, self-determination, right, and supporting and moving with. So I'm going to say, Pam, bingo, kind of having a whole repertoire, and that SAVE being able to sort of step in and out of some of those different kinds of leadership styles, if you will, or leadership skills and tools.
And here's another one, Alan. Hi, Alan. Is commenting here, many of our leaders in public health are not nurses. Can you comment on the relevance, applicability of the research and literature as we work within that other team that Alwyn has mentioned?
Well, what's interesting, Alwyn, is that in the 27 studies, nursing and nurses was present, but really no discipline actually emerged as being sort of more dominant than others, if a discipline was even mentioned. But you are right that in terms of nursing in leadership roles, but the applicability. So that's why I linked it back to CNA, so nursing writ large, if you will, and how CNA has described nursing leadership. And I linked it also and sort of set the stage, I think, in terms of public health and community health nursing and what is published and what is there around that. So I don't think it's offside from what we would consider to be solid nursing leadership. In fact, I would say that nurses hold these skills, in those that I know, in a really strong way. I've said this before, and I really think one of the things that we have to do as nurses is call our work leadership. And I've said before, too, if you're uncomfortable calling your work, you heard that in my description, that actually the work or the implementation or the delivery of programs and services is actually and was seen in those studies as leadership. And if you can't call your own work leadership, then call your colleagues' work leadership. Like when I saw Alwyn do that, it was very strong leadership, right? Name it as leadership. Call it leadership.
Great. Any other questions anybody has before we end the webinar? You're certainly welcome to add them to the Q&A like we've had just now, and sure, if there's others while we're chatting, just add those comments, and this will be an opportunity for Claire to respond to anything from what she has mentioned, but I think particularly, where do we go next? What are some of our actions that we as nurses need to think about in public or community health nursing around leadership? And clearly with Clara's presentation, she's really honed in to health equity, which is very much a foundation for what public health nurses are involved with. So, and if you can't think of any questions at this point, that's fine. Feel free. You can still add them, and we can respond to them as well.
Okay, and I think we're going to put up another poll here, and what we're asking you for is, what are your ideas for action? So kind of the so what question here. So I've got a few slides. I'm just going to go through them, but these are sort of some of my ideas. And I approach these actions not from, I told you my leadership journey earlier, and I really highlighted my involvement with professional associations, whether it was the Association of Registered Nurses in Manitoba, or whether it was, my long-standing, very positive relationship with the Community Health Nurses of Canada, or whether it was with the Canadian Nurses Association. So that's kind of the angle I took here, even though I do have other roles and other leadership opportunities. So in terms of action, and I think we have to claim our leadership space. So claim your leadership space and collectively. And I've got a few things here, but we are knowledge workers. We're in every neighborhood and community across this country. We need to work to full scope. We need to do what we were taught to do, and try to really push to the edges of that scope. And we, of all of nursing in community health nursing, really need to be looking upstream to address those social determinants of health and paddling as hard and as strong as we can. Now this is to click. I'm hoping, I need to click here. We need to, as the NCCDH suggests, build and lead a culture of equity. We need to make social justice clear. It is, I think it was, I know it was Adeline Falk-Raffel who said that social justice and practicing from that space is a manifestation of your caring, of our core of nursing for a community, for a population, for a society. We need to work downstream, as I said, to meet the needs of diverse populations that are all around us. I named those 5 that Sister Elizabeth Davis, and I know that you're all paying attention and working with those populations. We need to bring solutions. We are a solution in and of itself, but we need to bring our solutions, what we know to work. If we can't do it ourselves, then find somebody else who can do it where it's safe for them to do it. I would suggest some of the professional associations who claim advocacy as their role. You need to lead change. Leadership is about change. We did talk about that. Change, empowerment, but change. You need to work in the domain of policy. Some of the most significant changes and health impacts have been in that area of policy. You may not work in policy, but you know somebody who does and can influence that way. We need to consider reconciliation. I said earlier about our First Nations people. We need to work in that spirit of reconciliation, build it into our work, build it into our conversations, build it into what we're doing and thinking about, build it into our own personal development. We need to be good partners, good collaborators, and I would suggest allies. But most importantly, we need to be at the table. And CNA is at many high-level tables, political tables. So has the capacity of Community Health Nurses of Canada. How we get there, I just think we need to be at whatever tables we can get to. So ask yourself the question, am I at the table? Can I get to the table? However you define that table or opportunity to be. I'm constantly building my leadership skills. I know that I come up short in some of them, and I come up short often in some of them. So I'm constantly trying to educate myself to model other respected leaders, people who I admire. Sometimes it is about imitating or mimicking or trying it on, right? And accept invitations to get involved. Invitations come our way all of the time. And when somebody taps you on the shoulder, my suggestion would be to say okay and to get involved. And I know for me, the Community Health Nurses of Canada was an incredible opportunity to get involved. It was good for my soul. It was good for my mind. It was good for my social relationships. I've made many long, fast friendships and relationships through it. So I would encourage you to get involved. In the very near future, there's a leadership institute being developed or put on in June in Ottawa by the Canadian Nurses Association here in Manitoba. Our association brought it to Manitoba, so it could be available in your province and territory if that's something that you're interested in. In June, also later in June in Regina, is the Community Health Nurses of Canada conference, and as Ruth talked about, there's a Leadership Institute within Community Health Nurses of Canada as well. So I'd encourage you to try to get there, and I'm glad you're online today. Certification. I talked about my leadership journey and being a certified community health nurse, and there's about almost 1,000, about 900 registered nurses across the country who have their community health, Canadian Community Health Nursing certification and the designation. And it's important, and it's an important marker, if you will, for that specialization and for that pursuit of excellence. Use the tools, both the Community Health Nurses of Canada as well as all those NCCs out there and CNA have tools. They're relevant. They're current tools and on very relevant and current topics. And these are just a few: harm reduction, school health, immunization, social determinants of health, health and all policy, those kinds of things. And if you don't see them, ask for them. Ask for them because they may be already in development, and maybe you could get involved in helping us develop them, whatever the us is. And finally, I think we have to work from a collective action or collective impact perspective. So where it's not necessarily safe or you don't necessarily feel comfortable within your own workspace or your work organization, come on side with others, CNA, CHNC, because we really do need to work collectively to build a sustainable health system, to keep a sustainable health system, and to work towards optimal health and well-being for all Canadians and all of the people who live in Canada, as well as a united and vibrant nursing profession that I have been proud to have been part of for 41 years. So those are some of the references, and I thank you. I thank you for the invitation and the opportunity and for your feedback and your comments.
Thanks, Claire. And I just want to highlight some of the comments that two participants have commented on, and that we need to be able to identify that, yeah, we're doing that, but we need to stay on the path. And that's an action that we need to continue to do. That's our agenda, and we need to continue with that. And then the other comment I think was significant as well is that to better utilize the power and influence outside our employment settings to bring about change in the system, and to accept leadership, and to gain a greater support of those designated leaders. So I think those are great challenges that we can take away from hearing from those on our webinar. But thank you very much, Claire, for giving us the opportunity to look at this aspect of leadership and how we need to continue and go forward, as has been mentioned. So thanks again, and again, if there's any questions, feel free to add them. We will not lose those at all.
Thank you, Claire and Ruth, for your presentation. We're just going to ask a few poll questions of you. There's two here. The first one is, using the following scale, how likely are you to use the information provided today in your day-to-day work? And the second is just to give us an idea of the true audience. So if there are any people in the room with you who didn't register for this webinar, we're just asking how many. So I'll leave these open for a few minutes. So it looks like most of the participants have responded, so I'll just wait a few more seconds and then we'll close these. Thank you so much for your responses. So if you have any other questions, I'll put up the contact information for both Claire and Ruth so they can be reached at the email addresses there. And as Ruth mentioned at the beginning of the webinar, we record all of our webinars and post them on CNA's YouTube channel in the Progress and Practice playlist. So they can be accessed there, as can the other two webinars in this series that we did with CHNC. You can also download a PDF version of the presentation and your certificate of participation under the webinar. And there are links to the CNA's Code of Ethics for Registered Nurses, as well as the Public Health Leadership competencies that are there below the webinar now. Just a reminder, if you haven't already, both the CNA Biennial Convention and the National Community Health Nursing Conference are in June this year. CNA's is in Ottawa and the Community Health is in Regina. So registration for both of those can be found on our respective websites. So thank you so much, Claire and Ruth, for your presentation today. And thank you, everyone, for all of your participation. This concludes today's webinar. So have a great day, and thank you.
This concludes today's conference call. You may now